Anyway, I think we'll get some closing remarks now from Professor Anastasiadis about the last 10 years, a really remarkable milestone in the development of the society.
Well, thank you, John. And Serdar, it's really honor for me to lead you through art and quotes to this 10 years pathway that we've been all together when this society was established, founded, and we've reached now to the point that we can have this 10-year anniversary. So actually, what we've tried throughout these years is to find out, to define, or to advocate that MiECTiS is the state of the art, as we keep saying. Now, how can I picture this 10 years anniversary? I don't know. It's pictured otherwhere. But what I would say is that everything started actually 30 years after the development of cardiopulmonary bypass from John Gibbon, where things have started to go to the open heart surgery, and it was a really revolutionary development because cardiac surgery became routine after Gibbon's heart-lung machine. But it was Kirkling that found out that we have damaging effects that comes with CPB in cardiac surgery, and that was actually depicted in the clinical outcome. As you can see, that there is actually remote organ dysfunction post-operatively. So with this early 90s, late 80s, 90s, some years after Kirkling, OPCAB, off-pump coronary artery bypass, started to be the most favorable clinical attitude in cardiac surgery, though what we found is that throughout the years, it was just CIS that maybe is less, and actually there was no reduction in operative risk, though you might say that there is excess mortality at follow-up and higher risk of repeat revascularization. So with this OPCAB isolated to experienced hands, and mainly, as you see here, countries that are developing and they cannot afford devices and all the consumables from companies, mainly, as I have said before, India and Colombia and other countries. So with this, there was an emergent need of what Mike van Driel and Yves Fromm have stated, find something simplified with less side effects, but trying to promote science with it. And that was MiECTiS, early 2000, and this is the very first paper from Regensburg, 2004, which was the clinical one that made a lot of impact into the literature, and there were voices about how oxymoron is minimally invasive, minimal invasive bypass, and as you see, they started to quote about mini or maxi. So the question was, is this mini extracorporeal circulation system an evolution or a revolution? So some years, a decade after, we came into the literature with the verdict that minimally invasive extracorporeal circulation is a revolutionary evolution in perfusion. And this is actually what I still believe. And why is that? This is because there's been a background, early clinical years that, as you see here, MiECTiS actually reduces mortality as well as significant morbidity. And that can be found also when we are discussing to OPCAB. And if we try to see which of these three techniques, conventional bypass, off-pump surgery, or MiECTiS, is better. Obviously, even in this very big network meta-analysis, MiECTiS is superior. So with this, we've reached to the stage that we were ready as scientists all over the world to start the era of MiECTiS in this first international symposium in Thessaloniki, 2014, where we've founded MiECTiS for dedicating it to the investigation, support, and further development of physiologically based perfusion and related technologies, and hence to the wide application of MiECTiS in clinical practice. That was the statement for establishing MiECTiS as an international multidisciplinary forum and comprising anesthesiologists, perfusionists, and surgeons, as you can see from the founding constitution. And as you see here, the seat was Thessaloniki, and it is surprising that all the major societies of our specialties have base in Northwestern Europe and Northeastern American cities. And it was the time that we have a society seat somewhere to start from the classic and going to the digital, to the AI era as we have now. And for this, for the first beginning, we emphasize that this society, this convention is for innovation and future. So that was our logo that we keep having, Convention for Innovation and Future, because that was what we were visioning regarding this technology, which, as you see, is a field for research with a very wide spectrum of research topics that you can go with, like cardiac indices, heparin, point of care coagulation, fast track algorithms, RX, patient blood management, components design, microcirculation, brain, goal-directed perfusion. And for this, there is a huge space for trials. So as we have high volume data to further evaluation, the implementation of this technology in clinical practice. And of course, we didn't forget at those stages that minimally invasive cardiac surgery was the future. It is now the presence, but for us, minimal invasive term in mix is often misleading because it mostly refers to a cosmetic approach rather than a true minimally invasive technique for the patient. And that's why we thought that the integration of MiECTiS into mix. And also, we didn't forget that, especially for the pediatric population, it should be a core technique, a core strategy, so as we minimize the side effects that comes with cardiac surgery in pediatrics. So this is the founding members and the steering committee, the first from 2014, great people, all of them really opinion leaders in the field that managed to have this consensus meeting in Bern, where, as said by our president, Cyril Serik, we managed to bring order from chaos, and we defined the dispersed terminology that was into the literature, and also to say that mini is not proper because here we are referring to minimally invasive and not to the size. And to define that, we managed to integrate what Mike van Driel has said, to integrate the technology that has been researched throughout 80s and 90s to this mini CPB, which is actually 4+1 features. It's a closed circuit with no blood-air interaction, centrifugal pump compared to the rollers, and inner surfaces bonding, and of course short tubing, so as hemodilution should be much less. And if you add the necessity for a cell saver, because there's no for a policy for bringing back the shed blood to the circulation, then this is the mini CPB that was distributed early 2000, and in 2014 we had defined with these features what should be the main components of a system to be defined as MiEC, or any peripherals that can be added, integrated them into the system. With this, as John Murkin pointed out, we managed to have results from the literature to compare apples and apples, and not apples with oranges. And that was our intention from the first beginning. And we had to go for typing, for trying to differentiate the types of MiEC systems, so as we have the common language, again, with comparing and with using these systems, where we managed to persuade the perfusionists that MiEC is not just a circuit, but it's a system, holistic, forming a strategy which is multidisciplinary. So MiEC actually is a procedure for the society, which made two breakthroughs in the literature from the first beginning: the strategy and the teamwork that are true multidisciplinary. So multidisciplinary strategy and the multidisciplinary teamwork is what this society advocated from the first beginning. And of course, we shouldn't forget that we managed to have this position paper, which came from 35 authors, all three disciplines, from 24 departments. And for the first time, we have introduced into the literature that there is level of evidence A and class 1 in using MiEC in several parameters like blood management and end organ preservation. So we need to say that in the contemporary cardiac service, the most advanced techniques that is used are transcatheter or hybrid techniques, video-assisted or robotics. And you can say that if this is the future, or which is these are the advancements, why we should refer to MiEC. And I can disclose that behind all these techniques, it's a perfusion machine. It's a heart-lung machine. So perfusion is linked to cardiac surgery, very, very tight. And we don't have open heart cardiac surgery without this CPB, which from the years of Gibbon and from John Kirkling, early 80s, it's still bringing some side effects or some morbidity, maybe mortality as well, because as you see here, it is in the real world a significant maze that comes with cardiac surgery, and we shouldn't neglect that. So for this, MiECTiS has tried to disseminate the message of minimally invasive cardiac surgery through its events. And this is the second symposium in Athens, 2016. And 2 years after 2018, we had in Bern a very big symposium. And then we've started to have in alternate years the update meetings. So as we filling the gap and having every year an event to keep on with the message for the literature. And we have 4 update meetings here in Thessaloniki. And we didn't stop even the years of COVID. We switched to completely online, as you can see here, with virtual symposia. And that was a landmark to our society, that we moved from Europe to Canada, and we managed to overcome what there was the criticism from the Americans that this is a European technique. So we were in Canada, and we have the symposium 2 years ago with the presidents, Cyril Serik and John Murkin. And in total, we managed to have in 10 years 12 events, 5 symposia, 4 update meetings, and 3 other meetings, which I believe it's quite a good record for a society that has no financial incentive and is a group, a multidisciplinary group of motivated opinion leaders trying to promote this technology by educating and researching in the field. So these are the record that we had throughout these 10 years. And I could say that regarding the society, we managed to 4 times multiplied our founding members. Now we have roughly 450 members coming from 49 countries in 5 continents. And as you see here, we have quite a good number of surgeons, but we lack some anesthesiologists that we need to persuade that they had to be stakeholders in this business. And with this, I need to thank and actually to appreciate the hard work that is being done by the board of directors, people that are these leaders, that they have the vision, they have the commitment, and they put a lot of effort throughout these 10 years for reaching to that point that we have the society, which is active. And as you see here, we have an interest not just in Greece, but mainly United Kingdom and Italy. And if we split the disciplines, you see that there is a United Kingdom everywhere, Italy, Germany, and surprisingly, there is a lot of interest in America, in North America, both Canada and United States, which is not translated, Mike, to clinical practice. So there is scientific interest there, and I can tell you that you can see it here, where you find the web page viewers, and you can see that actually United States is leading to this 70,000 page views. This is Google results, and actually our web page is not even a portal. It's just a society page which indicates the events and nothing else. And throughout these 10 years, we have 70,000 page views, and this comes surprisingly from United States mainly, India, and Australia. And I'm surprised because these 3 countries, they do not have clinical practice on MiEC. So let's go on from what we have done to educate. Well, I would just share my own experience. I've been to many EACTS and UK meetings. I tried to be everywhere, and I tried to give talks to several continents, initiating the idea of minimally invasive extracorporeal circulation, and tried to pass the message. And I could say that we managed to have a lot of people that came on board, and also with our educational trainings by the aid of the companies. And of course, we had books, and we've written with my team colleagues a lot of chapters to all the big perfusion books, the international perfusion books. Also, we have distributed with the Secretary Polychronis Antonitis a lot of newsletters, and our past president Thierry Carrère, who last minute couldn't be here, but he has put a lot of effort to this society. And as you see here, we have also managed to have a very big dedicated issue on this journal regarding this technology. And we shouldn't forget that lately we managed to have an official journal, Perfusion, that we published. Now, what we have accomplished with all this? Well, we managed to be integrated into the evidence-based medicine. That means we are now in the guidelines, as you see, the EACTS, European Association of Cardiothoracic Surgery, and European Association of Cardiothoracic Anesthesiologists, EACTS and EACTA, integrated MiECTiS into the 2017 guidelines. 2 years after, these two societies, including the European Board of Cardiopulmonary Perfusion, Clinical Perfusion, they've included MiECTiS also in their guidelines. And surprisingly, 2 years after, the Americans, the Society of Thoracic Surgery, the Society of Cardiac Anesthesiology, the American Society of Extracorporeal Technology, and the Society of American Blood Management Society integrated also MiECTiS into their practice. So there is sufficient evidence, irrespectively if you consider it to be class 1A or class 1B or class 2A, it is still there. It's how you look at it. And I can tell you, when we try to review the literature, to update the position paper we had, we managed to find out that it's for us class 1A evidence, because it's sufficient data there that there is no superior technology in cardiac perfusion rather than MiECTiS. And we found out also that quality of life is favored by using MiECTiS. And also, if we trying to find quality of life and cost analysis, so we go to value-based healthcare, as has been suggested. Again, MiECTiS is dominant technique as compared to conventional one. A lot has been said early years, and I found no objection lately. Wherever we go, I go and give lectures about efficacy and safety. So safety, there is no concern anymore, because as you see here, to this very big analysis that we've done, there is actually no adverse event in the literature regarding any safety issue. Most of these are the only reported troubles. And as you see here, it's only air entrapment in type 1 circuits, which is, for me, it's mainly historical. And in modular, we need to have conversion in some cases, which is absolutely compatible to what the modular system is. It's a hybrid system that you can anytime convert to open when you face any trouble interruptively. That's why, for us, this is the way forward, and that has been said by Ashraf and Lasawi, that we should advocate that we just need type 4 systems to be promoted into the clinical practice. So let's go to the biggest trial that has been done. It was COMICS trial that we managed to start, and unfortunately, due to financing problem and to pandemic, we had to stop the trial. However, we managed to recruit 1,057 patients. So this is the biggest trial ever in this topic, and you can see that our statistical number favoring MiECTiS is P02. So 0.02 is a very, very strong statistical number that is favoring MiECTiS. And as you see here, this is because the primary outcome events, which were very hard endpoints in this trial, were reduced from 13.2 to 9.7. So this is actually a huge success of this trial. And as you see here, there are also other background effects, like stroke rate, which is actually very significant lower in the MiEC arm, and quality of life, as you see here, which is significantly much better when we operating on MiEC. And for this, the paper is submitted and is about to be published in the Perfusion Journal, but we are planning to do a clinical paper, which we will bringing forward a lot of subgroup analysis and also all the clinical implication of this paper, because otherwise a dry statistical analysis for me is not the proper way to go for. And of course, what we've done is since we had to stop due to the reasons that I have mentioned, comics, we have started already a new trial which is even more contemporary oriented. We are now comparing MiEC to OPEC, and we have 12 participating centers. 4 of them already started, as you see, and we have about 10% last month with MiEC's trial, and we hope that in the next 2 years we will be able to finalize it and have another big randomized controlled trial. And I believe with MiEC's we will have definitely class 1 level of evidence A, and that's it regarding data that needed. Data is sufficient, it is there, and no one can admit that there is any opposition that MiEC is better and MiEC is safe and MiEC is feasible. For all this, what John Murkin has written some years ago is that MiEC has been associated with a variety of improved clinical outcomes and actually improved microcirculatory perfusion, which is the base. And this is why we believe that with thorough monitoring in both anesthesia and perfusion, we can actually reach to what we say it should be the state of the art, a multidisciplinary preoperative strategy for attaining a more physiologic cardiac surgery. And for this, I would say I can award it as the gold star of MiEC. I would say that we need a true teamwork, and I need to sincerely thank my team that throughout the years they have dedicated their research and clinical and as well as educational efforts towards MiEC throughout the years. And of course, by putting all together what I have mentioned so far, you can say that operating on MiEC, what you have is a therapy for your patient. So you do not only treat the surgical part, but you respect physiology, and at the end what you have is a patient that received a therapy. Now, I would go for the global need of MiEC, and you can see here that ECMO therapy is actually required in about 70,000 patients per year globally. Well, this number in cardiac surgery is more than 85,000 patients if you exclude the OPCAP cases. And so you can say that about 1 million of cases might have a MiEC, and this is an incentive for the companies if they want to invest in this technology in parallel with ECMO, which is something much less needed in the clinical practice. And of course, for the anesthesiologists and for everyone who is saying that advocating ERACs, many years ago, we said that if you operate on MiEC, you actually create conditions as off-pump surgery. So I can't believe that there is any kind of true ERACs in cardiac surgery without employing MiEC. It's like doing the same as surgeons that are advocating MICs, that are actually promoting how small they can be into the access. Because otherwise, if you don't have MiEC to transform it to a physiologically based surgery, MICS itself is just employing transcatheter techniques or innovation in devices into maximal invasive perfusion strategy. And for this, the Bob Kiai, the president of ISMICS, at those stages, he said that we should work together, the societies, MiECTiS and ISMICS, so as we will find the way to actually pair the procedures as you see here, because we said that it takes two to tango, and MiECTS can't have one without the other. So this is the future, and to me, this is the present. So what next for the society? I would say that MiECTS is the next milestone that is coming, and I believe we should be able in the next couple of years to finalize it, and then I don't believe there will be a need for any more randomized control trial trying to identify if MiECTS is better or not, because so far there is no trial, zero, in all the literature, as you have heard in the morning, that advocates any other technique rather than MiECTS as the best technique ever exists in the whole literature all these years than MiECTS. About teaching, where I have heard a lot of times from a lot of people, and that is Alexander Wachba, former president of EBCP, advocating that we should integrate MiECTS teaching in perfusion schools. Well, I think that the time has come, and also we can integrate MiECTS post CPB school, so into the practice of the professionals. So we should have MiECTS Academy that will give them all the insight and the proper training for having integrating MiECTS in their practice. For this, we are about to launch this e-learning tool, which is called Massive Open Online Courses, MOOCs, and we are cooperating with EBCP to finalize this e-learning for all people, especially perfusionists, surgeons, and anesthesiologists that are interested to familiarize themselves with this technology. And of course, what we will need soon is a very big textbook, because a lot of knowledge has been accumulated. And as you see here, both Serdar's book and our book are already old, are more than 10 years. Of course, as I have said, we have written a lot of chapters to all modern contemporary perfusion books, but I think we need a big textbook with all the new techniques and news and research for this technology to be published. And a more important issue, as I have referred in the morning, is that we need this database that we have started in Thessaloniki and will be ready this year, a very big database, including all the papers that are dispersed in the literature on MiECTS, which is some less than 1,000. So we will try to have a big registry that will be offered to all of the MiECTiS members, so as they could do any kind of analysis, meta-analysis, retrospective, any kind of extensive review of the literature, any kind of narrative review or whatever, because I believe that the power in evidence-based medicine is data. So that would be a great offer of MiECTiS to people. And finally, starting MiECTS programs. We are about to start MiECTS programs in several countries that we are collaborating to start with after the COVID era. But I would say that for me, there is no hesitation rationale, because if it is the evidence, I believe that the problem is minimal information of the guys that are saying this. If it is concern, I would say that this is more unwillingness to discomfort rather than difficulty from complexity. So if you go for it, for a MiECTS program, what you actually need is a multidisciplinary teamwork. And the result that you will have to your patient will definitely reimburse you. As far as the scientific and commercial interest, it has been said multiple times today that there is a huge market and a huge possibility in United States that we try to penetrate. And as I have shown you, there is an interest there that can be expressed from attending our congresses, even from CTSNet. But if we want to integrate MiEC into the clinical practice, what we need is the perfusion services in the States to start promoting, as Mike Van Driel said, quality of perfusion, not the cost or simplicity. And of course, China or other developing countries, they do have a lot of possibility. But what Professor Baker from Adelaide, Australia, has pointed out is that we still are in the very early phase, in the early adopters. So we need to do the early majority phase before we say what Yves Fromm has stated, that we didn't manage. We keep trying, and we are not in the downslope. We are still climbing, and I believe that the problem of non-uptake of effective clinical innovation is long-standing and persistent, as it says here. And to be honest, this is likely the rule rather than the exception. So we are not the exception, we are the rule, because as you see here, there is a gap between research and practice that is estimated to be about 70 years on average. And actually 1 out of 7 evidence-based intervention make it to be routine in clinical practice. And the 4 out of 5, they will never find their place in clinical practice. So with this, I will conclude about this 10 years journey in MiECTiS. What Robert Guyton, former president of the WATS, has said is that cardiothoracic surgery will survive because enough of us will innovate. So we need innovation, as we stated from the first beginning of MiECTiS establishment. And if I will try to define what MiECTiS has done over the years, is that it formed a group of scientists that is true multidisciplinary. It has driven the industry to go for the technology that has been defined by the society. It has also tried a lot through research to integrate that to the guidelines and to educate through meetings so as to expand this technology. Finally, we managed with all this effort to bring into the forefront the optimized ECC, the OPEC, and abandon the conventional CPB of Gibbon's years. And definitely what counts for the society is advancement of patient care. So as I said, optimized ECC, I believe it's the way to minimize the pump, but it's not enough, because we have multiply demonstrated that OPEC as opposed to MiEC is inferior. So MiEC offers statistical benefit regarding to OPEC, and we need to use OPEC as the first stage to go to the state of the art, which is, as Elena pointed out in the morning, that MiEC is the state of the art because the base is microcirculation, the integrity of microcirculation, and the optimal end organ perfusion that it offers. And I'm very glad that my colleague Polychronis and our senior fellows Marco Ranucci and John Murkin have been co-authors to this very big message that we brought into the literature, that more physiologic perfusion is mandatory when we're discussing about cardiac surgery, and MiEC should be integrated in the clinical practice and become the standard. For this, we need to keep implementing MiEC in evidence-based medicine and all future perfusion guidelines, as Rob Baker has stated. And of course, we shouldn't forget the companies that throughout all these years are really supporting the society, cooperate, but also participate into the scientific sessions as partners. And I really want to thank and congratulate for their attitude so far. Can I have the voice? The voice. Now, as you will see, wait, sorry. I need the voice of this. As you will see, we managed to give to the industry some insight so as to make them refine their technology. No, we can't hear. Can we have the voice, please? No, from the beginning. Go from the beginning.
The previous meeting,
No, not the slides from the beginning. Go to the slide and start the video from the beginning. No, more. Yes. But you have to tune up the volume.
in the previous meeting, I was presenting to you our new solution in terms of oxygenator module for the minimal invasive as for recirculation. And after the previous meeting, we were, let's say, diverting our R&D people in a brand new solution for a venous reservoir.
Yes.
Sorry, it was honestly developed after the previous MiECTiS meeting because we had something but was not really in line with our let's say expectation, and we developed something new as an asset, including an innovative fluid dynamics derived from a university here around, and we will promote for sure these techniques around Europe.
Right, even though I don't hear it well, what I want to indicate is that we managed to drive companies to follow this technology that we are advocating. So regarding the incentive for the companies, as you see here, this is the update meetings. And so far we have about 150,000 views from the update meetings in our webpage. Regarding this meeting, we have more than 10,000 views already in the first day, more than 320 registrations, half of them on-site delegates, and more than 350 online participants. And if you go and review the big event we had 2016, there are 325,000 views already. If you put them together, you see that 500,000 views of the initiatives of MiECTiS are there. And these are Google statistics. It's not my statistic. And this gives the necessity of this society and how scientists are eager to follow society's initiatives. And I would urge the companies to keep endorsing us and keep helping, because this is what we would need to give to all these people. The ultimate outcome from all this is advancement of patient care. And this is what we are advocating as society, and that's why we would need all together to have the same attitude and the same vision, because what we actually are here is a group of people that they are not just scientists, but they discuss, they socialize, and with this I will lead you throughout the 10 years event from MiECTiS with this video. Well, thank you all for your attendance and for your 10 years MiECTiS. Thank you. All right, so I think we have some social events that we will start in 5 minutes. There are some buses outside. Thank you for today. We'll be here tomorrow for second day of MiECTiS anniversary meeting. Thank you.